I've had the great luck doing this program to chat with a lot of really smart and prominent people. But I have to confess, I'm a little more nervous than usual today because I'm interviewing my big sister, Dr. Suzanne Salamon. From the time I was born, I relied on her to explain the world to me and to keep me from getting in trouble with our parents. 4 years ago, I came to rely on her in an entirely new way. Our mother, who epitomized the word indomitable, was living alone in Florida at age 98. Shortly after the pandemic began, she fell and cracked her pelvis. When she got out of rehab, I flew down to Florida and brought her back to New York. We had a great relationship, but when my sister and I told her she had to move north, there wasn't a question. She was moving to Boston to be near Susie. My sister's a doctor, a geriatrician no less, clinical chief of geriatric programs at Beth Israel Deaconess Medical Center. The plan was for our mother to move into an independent living place near Susie's home, but the pandemic was on, so we decided she'd stay with Susie and her husband, Alan, until the pandemic lifted. Well, flash forward, my mother stayed with Susie and Alan for 4 years until she died this past June. She was almost 102. National Family Caregivers Month begins on November 1st in a couple of days. So today, we're really lucky to have someone who is a caregiver daughter, who also was her mother's physician. Welcome, Dr. Salamon. Hi, Susie.
Hi, Julie.
So, so we strangely grew up in Appalachia, in a very small town in southern Ohio. The population was 800. Our parents were Holocaust survivors, and our father was the town doctor. Susie, what do you think in our childhood experience led you to become a physician?
Well, our father was a doctor, a practicing doctor in Europe. He was married before, he had a 2-year-old child, and both his wife and his daughter were murdered during the Holocaust. So after the war, he married our mother. They were in Prague for a couple of years, and then they came to the United States when their visa finally came through. He had to redo his residency in New York and then look for a job. He had a hard time finding a job in New York, and so he eventually found one in this small town in Ohio, which was near the Kentucky border. It was a weird place for a Jewish family to end up. We were the only Jewish family in town. This was real Bible Belt. And yet, despite this, he and our family were welcome with open arms in this small town. And I think it was really a healing for him. He told me from the time I can remember, a little girl, that I should become a doctor. In retrospect, it's funny that he would have said this because he was an European man who really never saw professional women, or rarely anyway, but he always said to me that it was a beautiful profession and that I should go into it. So as the years went on and we watched him, his office was attached to our house, so it was pretty fluid. And the town loved him and loved our family. So I always felt that being a doctor was, respectful. And according to him, it was a profession that you could carry with you. So it was a real refugee mentality that you could pack up your MD license in a bag and flee wherever you need to flee. One particular time I remember was when I was, I don't know how old, maybe teenager. And it was during the height of the Vietnam War. And I remember in the middle of the night, there was a pounding at the door, pounding, pounding. And I was sure the Nazis were coming to take us away. But instead, it was an older couple. I mean, I guess they weren't that much older. At the time, they seemed older, who came to the front door in the middle of the night because they had just received a telegram telling them that their son, who had been fighting in Vietnam, had been killed. And the woman went completely crazy, screaming, and her husband didn't know what to do with her. So he brought her to our father, who kept her in the office for a long time. I don't know exactly what went on, but by the time they left, she was calm. And that has really stuck with me through the years, that perhaps being a doctor is a way that one can help people who are in crisis.
Yeah, and as you're talking, I was thinking about that our house was attached to the office, and then you ended up taking care of our mother at home. I almost called her mommy, which I may do during that, because up until the end. And you were just telling me the other day, which I noticed we're also dressed alike, which we didn't plan. But I was, you had told me really how you became a geriatrician, and I don't think I knew the exact story of that. And so before we get into the actual caregiving conversation, first of all, if you could just tell people what a geriatrician is versus an internist, and then how you ended up going down that road.
Yeah, a geriatrician is an internist or family practitioner who then takes additional training in geriatrics. It's a fairly new specialty, probably maybe 25, 30 years old. And it's deals with people who are age 65 and onward. The whole age 65 is pretty arbitrary. It really came around many, many years ago when people weren't living as long as they did. Really, people are living so long now that we're thinking of bumping up the age from 65, which seems so young now. But truthfully, and we deal with things like osteoporosis and memory loss and just all kinds of things that people deal with as they grow older. I actually never in a million years would have thought of going into geriatrics, because when we interview people for our fellowship program and they write a personal essay, it's almost always that I had a grandmother or grandfather that I was really close to and that inspired me to go into geriatrics. But we didn't have grandparents. All our grandparents died in Europe. And so I wasn't really exposed to older people. So it really didn't occur to me until I was finishing my internal medicine residency in Boston, and I was single and I was in my 30s and wasn't having any luck finding anybody. So I decided that I would move to New York, where there was a bigger group of single men to choose from. But of course, as life or fate has it, I met my husband, Alan, just before I was packing up to move to New York. And even though he said that we could manage a long distance relationships, I thought, why chance it? And so I ended up staying in Boston. And I started scrambling around for jobs. And one of the jobs I found was at a public health hospital here in Boston, the Lemuel Shattuck Hospital. And they had a 50-bed geriatric unit. And they put me in charge of it. And that was really the first exposure that I had to dealing with only geriatric patients. And I found that I loved it and ended up staying there for almost 20 years. I did a fellowship where I am now. And then when I got a job at Beth Israel almost 20 years ago, I've been in it ever since.
Great, lucky for your patients. She also has some non-geriatric patients, like my children, who have called Aunt Susie as always first point of departure on all of our family illnesses.
Yeah, and it
Somebody
always
in
makes
the
me nervous, because what do I know about those pediatric things?
everything. They're all grown-ups now anyway. So somebody in the chat asked where we were born. Susie was born in New York, and our mother was actually 7 months pregnant with her when they moved to Ohio. She came to Ohio alone on a train with my sister, 4.5 years old, and me in utero. So just to let you know what a strong person she was. Um, you know, to get to we'll get to the caregiving part of this in a second, but as a physician, When do you notice your conversations either with your patients or with their families start to change from, how do you stay healthy and, just sort of normal doctor conversations to sort of how do you prepare for the end? Or when is the time that kind of a little alarm bell goes off for you?
It's so varied. I mean, there are people like our mother, not that many, but there are people who are in their 90s who are completely independent. And then you have people, actually, my youngest patient is in her 50s with early Alzheimer's disease. So I try to make it part of everyday conversation. You know, the old plan for the worst, but no, plan for the best, but prepare for the worst. So anyway, what I try to do with people, number one, is make sure that they identify a healthcare proxy. And I do that no matter how healthy they are. So the whole idea is if something catastrophic happens, they have a person that they trust to be their healthcare. Every state has something different, but to be the person that makes decisions for them in the event that they can't. I think it's really important to somehow get that healthcare proxy or surrogate either in the same room or on telephone so that when I ask patients what they want, the healthcare proxy hears it because there's a lot of stress and anxiety when it comes right down to it. So many decisions, not just whether they should be resuscitated or intubated, but feeding tubes and where they live. And it's really important for people to hear what what their parent or friend or whoever the healthcare proxy is. So I try to
So
start it really early.
yeah, and I kind of remember, I mean, we had done a bunch of that stuff with our mother, who was really quite good about all of that. And I think it helped that just coincidentally, we had two experiences of death. Our father died when I was 18 and Susie was 22. And then our mother lived for a very long time. So we experienced the early death of a parent and the later death, but our mother did remarry, and our stepfather lived to be 99. He was 10 years, 11 years older than our mom. So I think we had that kind of preparation. And yet, having said that, were you really prepared for thinking about mommy as old?
Not at all. Not at all. I mean, it was very helpful that she always told us that she did not want to be, if she were not herself, she did not want us to extend her life. And frankly, we saw this in action. You know, she made the decision with her father, and when her sister was in a terrible car accident, she was the one who told them to disconnect life support.
And
So,
then she almost disconnected Uncle Joe prematurely, remember?
yes, she did.
But we saved him.
Yeah. Well, what I see now in retrospect over the 4 years that it was a very gradual process, and that's what happens with so many people. You know, it's sometimes it's a catastrophic thing, like somebody will have a stroke or a heart attack or God forbid, a fall where they break their neck. So sometimes it's a real sudden change from independence to non-independence. But the majority of the time, it's gradual. You know, like with our mother, when she moved in with us, which Alan, my husband, said he would never in a million years do, but lo and behold, there we were. And she was in the beginning unbelievably independent. She loved the stock market. She was on that computer day and night with stocks, with her stockbrokers, with her emails to her friends. And then she would cook. She would make chicken paprikash. She would go outside every day, and she did use a walker, but she would go up and down our driveway. She would count how many times she went. So she was very active. But as the years went on, things started to change slowly. The biggest thing was she gave up the computer. She just stopped taking an interest in the stock market, which was unbelievable. Another thing was that she used to go over our grocery, the Star Market here. she used to go over the circular every week, and she would write down the things that were on sale, and she would give the list to Alan, and he would go shopping. In fact, I think the only fight they ever had was once he came home with the wrong chicken, the chicken that wasn't on sale. And she got very angry with him and told him to return the chicken, which he refused to do. But other than that, that was really the only problem that they had. She loved to read, but eventually she couldn't see the words in the books. So my son got her a Kindle, and she was able to make the size of the words bigger. So she loved that, and she was a voracious reader. But eventually she stopped reading. She just couldn't understand the words anymore. We used to watch movies together, old movies particular that she knew back and forth, and it got to a point where she just couldn't follow what was going on. She started to get incontinent, and so had to buy pads, had to buy pull-ups. Then there were the multiple doctor's visits to the podiatrist. I mean, these are all things that I hear from my patients and from my patients' kids mostly. But it really hit home when we were the ones doing it. Eye doctor, ear doctor, vaccinations, everything, everything was a job. She also really never lost her oomph. I mean, she was pretty with it, and she would still boss us around. She would tell us, tell me if she didn't like what I was wearing. But I think the difference was, which I see also, is there's this reversal in the parent-child relationship. And you have to walk a fine line between not wanting to make the parent feel like a child, and yet there does come a time where they do need to listen to you, and that can be tough.
So before we continue down that vein, somebody has sent in a very interesting question that could take an hour to answer, but I'm sure you can synthesize it. Did you see any, Miriam Shankar wrote, did you see any evidence of the Holocaust background in your family in terms of never having seen natural elderly death influence how you dealt with decay and death?
The influence of the Holocaust?
What did the fact that you had never really seen natural elderly death firsthand, how did it, I presume, Miriam, you mean deal with the decay and death of your own mother?
Uh, I, by the time our mother came to us, I really had, on one hand, written a lot of death certificates. So I had known that people die and, wrote notes to them and always called after there was a death. But I have to say, seeing it close up was very, very eye-opening for me. In fact, it was a picture that for weeks after she died, I couldn't get out of my head. I mean, I don't know how much detail you want me to go in for that.
No, but well, one thing I was thinking about is that the thing about, for me anyway, and I don't know if you felt the same, I think you did, was that for me, one of the most beautiful parts of watching this relationship was that I think we've always had a very close family and been blessed to have that. And part of that was our mother's force of will. She was a real matriarch in the best sense. But if you could talk a little bit about just watching her relationship with Ruby, your granddaughter, who was born really right before the pandemic, like 3 or 4 months before the pandemic. So Ruby was born, the pandemic came, and then mom moved in. And just what was that like, even in, because people in the audience should know this was all one of the reasons my mother ended up staying in Susie's house initially was because of COVID. So because we didn't want her to go to an independent living place where nobody could visit her, basically. So if you could talk about what it was like for you, I guess the sort of, and also what your relationship was like with her and how having her in the house changed that, or maybe didn't change it, but changed it.
Well, uh, I think growing up, there was no question that I was closer to my father and you were closer to mom. In fact, mom and I butted heads probably for the first 97 years of her life. And so I was actually quite surprised that she wanted to move in with us. I mean, I guess it was the practicality of my being a doctor. Um, and I was a little worried about that. And as the years went on, and I have to say, I see this with patients also, as the years went on, we got closer. And I think it was because I was less afraid of her. I think she was a little more dependent on me. And it's a it's a blessing, it's a gift that by the end we were really quite close to each other.
So we
And
got,
I see,
oh, go ahead. Sorry.
no, I see that with a lot of patients and their, and parents, and I do give that advice that, it's a good time of life to kind of move forward, appreciate each other, enjoy each other.
From Rob and Paul, hi, cousins of ours, but two questions that are actually sort of echoed by Wendy Soltz. How do you advocate for your parents if they don't want help, or if they don't think anything is wrong? I mean, I'm sure you deal with this a lot as
Oh
a
my gosh, this is
doctor.
really, it's a big problem. I mean, as stubborn and bossy as mom was, she was incredibly easy when it came to listening to us, accepting help. I mean, we did eventually, the last year and a half, we did have somebody wonderful, her name was Wenda, who came in 6 hours a day, really at Julie's insistence, because it was getting to be very hard to manage it all, the showers, and mom accepted it, even though she didn't want to pay for it. But again, that's pretty typical of that generation. That's a depression generation, and they don't want to pay, out of pocket to have somebody just sit there. But it's a big problem because a lot of older people do not want to move out of their place, even when they're falling, even when they're not shopping. And it can be really stressful for kids, for friends who don't feel that they're safe. A lot of kids get their parents the medical alert buttons, but the truth is that a lot of people with cognitive impairment or early dementia, and I will ask them that when I see it hanging around their neck, I'll say what that's for. And a lot of times they have no clue what it's for. So it's a big problem. And sometimes I will have to play the bad guy, which I'm always happy to do, and tell people that if they don't accept somebody in their home to help them, they're going to have to move out. And so a lot of times that's the option, that if somebody really is having trouble living alone, to move to an assisted living facility or to have somebody come into the home. They're both equally expensive, unless you have long-term care insurance, which very few people have.
So one piece of advice you would give to somebody would be maybe to get a third party, a trusted physician, or if they have a rabbi or somebody like that who they feel close to sort of act as the bad cop.
Absolutely, because sometimes when people are developing early Alzheimer's disease or cognitive impairment, one of the first things that happens is that people can get paranoid, think that whoever is trying to move them out is trying to take their money or has some ulterior motive. So it is good to have someone else. And I frequently will get emails or notes from family members saying, there's a visit coming up. Can you please address this? And that's very, very helpful. Also, for people who are far away, children, let's say, who don't live close by, can't go to the office visits. It's really helpful for them to be on the phone when the patient is in the office so that they can hear everything that's going on with the visit.
So I guess following up on this line of conversation is, so how do you manage, how do you assess and navigate? You can say this both as a doctor and from your own experience with our mom. How do you navigate when you should be interfering with them and when you should not? And it's, how do you manage your own anxiety about uh, the situation?
Well, one thing I've learned that I always do is I always talk directly to the patient, even if they can't understand me, because I know that whoever else is in the room with them or on the phone with them can hear me. And I think that gives the patient, even the patient with dementia, a feeling that they are more in charge. And I often will bring up our mother as an example. Like people who are, the children complain that they never move. I will tell them about mom and how she exercised every day and how I think that kept her independent. And, sometimes it works and sometimes it doesn't.
Um, so somebody wrote in with a great question or asking for comment from Steve Pollack. He says, some say age is only a number. Please comment on that idea.
Um, Controversial. Yes, I think there's no question that a 95-year-old can be, fact, um, well, they have an article that I just printed out today about a 90-year-old man diving into the water. Age is only a number, yes, but there's no question that as we age, our body does age. Now, there are people who are definitely healthier 95-year-olds than other 95-year-olds. And a lot of it we can control. And that's what's different about now and 25 years ago, is that we can really decrease the risk of heart attack and stroke by controlling blood pressure, by trying to be within a reasonable weight, not too heavy, not too skinny. Exercising, that seems to be the one thing that seems to stave off dementia, maybe not forever, but push it back a little bit, is to do some sort of aerobic activity, whatever they're able to do, whether it's dancing, whether it's, um, walking around. Any kind of exercise is really important. Not smoking, of course. Um, So there are definitely things that you can do. On the other hand, some people are born genetically with things that predispose them to to diseases, certain cancers, certain infections. That's why at age 65, there are certain vaccinations that we recommend for people, to get the COVID vaccines, to get the flu vaccine, the pneumonia vaccine, and I really push the shingles vaccine because shingles can be really awful. Tetanus shots, and of course the new RSV. So I push the vaccinations a lot and, just try to keep people healthy. I think
So,
that one of the worst things that can happen to people that can really set them back is having a bad fall so that they break their hips. So we stress the kind of things that can help reduce a risk fracture, like screening for osteoporosis and treating it if there is osteoporosis, making sure that their vision is good and they have cataract surgery so they can see better where they're going, that they see their eye doctors regularly, that they wear good shoes with rubber soles, that they have night lights in the bathroom, these kind of things.
yeah, I mean, it sounds sort of basic, but it's always amazing to me how many people um, don't do those things. Somebody wrote in to ask, how has gerontology changed over the years since you've been practicing? What have been the larger?
Um, I think that in gerontology, the biggest things are just the things that are in medicine. When I was in medical school, for example, what was accepted as a reasonable blood pressure was 100 plus your age. So if you were 75, it was perfectly acceptable to have that top number of their blood pressure be 175. We now know that that's not the case. So I would say that there's that, and then there's also the recognition by more and more doctors that geriatrics is or can be helpful even as a consultation. I mean, I think for so long, many internists and family practitioners felt that since so many of their patients were older, they were geriatricians also. But I think that our focus on health and prevention um, and dementia. I think that it used to be thought that people forgot things as part of normal aging, whereas we tend to try to decipher whether it is normal aging or whether there's some underlying process going on that can be slowed down, corrected.
Somebody kind of following up on that asked, is there a shortage of geriatricians in the US to care for our aging population? And then wanted to know if you're accepting new patients.
So it's a very sad thing, but I feel like geriatrics is a dying profession, believe it or not. The number of geriatric programs across the country, half of them have closed recently because none of the medical residents or family practice residents are going into it. It's very time consuming. Most of our patients are on Medicare, which pays the lowest of any of the insurance companies. And so people just don't go into it. I think 2% of graduating medical school students don't even want to go into internal medicine. People are just specializing. So, no, I don't think the future for geriatrics looks great, despite the fact that the population over age 65 is the fastest growing segment of the population.
Also, if there's anybody in the audience who's a philanthropist and wants to fund a geriatric program at a medical school, that would be a very big mitzvah. So we have a question from Sharon Goldberg about whether now that you see children of the Holocaust, second generation people reaching the age when they need a geriatrician or need doctors in general more, do you think that do you see patterns in children of the Holocaust in terms of their attitudes towards illness compared to the other parts of your practice?
Well, starting with the Holocaust survivors, and there aren't many of them left anymore, but what we see, and we saw this with our mother too, is as people become cognitively impaired, they will frequently have nightmares, flashbacks. We have people in the hospital who, when they're in the hospital and the nurses come to treat them, they think that they're Nazis. And often it takes a lot of reassurance and sometimes medication to calm them down. I mean, we saw this with our mother, how many dreams she had that she disappeared to the other world, saw that her mother didn't have enough food, and then decided to come back where there was food. And as far as the children go, I I think that not so much in medical care, but I think that they talk about the generational trauma for Holocaust as well as other traumas that other people may have. Um, that there's a lot of guilt, even survivor guilt in the second generation, and there's a lot of guilt that they have for their parents, in terms of not wanting them to suffer more.
Yeah. So somebody asks that a lot of agencies that she's come into contact with who are supposed to help with monitoring the aging process, such as geriatric care managers, seem to be sort of scams in terms of trying to avoid visiting the people they're charging for. Have you had good experience with agencies like that? And how do you evaluate them or recommend or deal with that issue?
So we have a fair amount of geriatric care managers, and a good one can be invaluable, although they're expensive. But for people who don't have families, or people whose families are in a different state or who can't come in with them, the geriatric care manager is like a substitute. They will keep track of the appointments. They will bring the patients to a doctor's office, take notes, bring in the updated medical list that they have of the medications they're taking. And they can be really, really invaluable. Um, this is true also for almost all states or cities have a council on aging or a senior center, which are sometimes federally, sometimes locally funded. And they often will have social workers who can do the same thing. So for people who can't afford it, who live in the town, they will often give advice or I've had them bring people to the visits. So,
Interesting.
yeah, they can be wonderful. And how do you tell a good one from a not good one? Mostly word of mouth, or somebody will come in and I'll get their card because I see that they're really excellent. To be honest, I have not seen a bad one. They really are people who seem to be very dedicated. A lot of them are social workers, a lot of them are nurses. So they've had experience in dealing with medical issues.
Well, here's the question that everybody wants to know the answer to. How does one determine whether forgetting names, events, sometimes how to get somewhere, is just part of a normal part of aging, or whether it's the beginning of dementia?
Sometimes you can't. I would say that universally, the things that people worry about that usually are not dementia are, I came to the kitchen. What did I come in here for? Or I can't find my keys. I can't find my glasses. Those things are typically normal, even if they didn't happen before. But things with dementia, and I will say that it also depends on the kind of dementia. In the United States, the number one cause of dementia is Alzheimer's disease. And people who have early Alzheimer's disease will sometimes repetitively ask the question over and over again, or will not forget the date of an appointment, but forget that they even have an appointment with somebody. Usually that person doesn't notice themselves that there's any problem. And if you ask them, if you have any problems with your memory, they'll be very upbeat about it and say, not at all. And you'll see the person who brought them in shaking their head or nodding their head. But then there's another kind of dementia, which is vascular dementia, where people are more cognizant that there's something wrong. Those things are usually caused by blood pressure issues, high cholesterol issues, smoking. And those are things that we have at least some treatment for. I think it's important to note that for Alzheimer's disease, we really haven't had good treatments up until now, but there have been new intravenous treatments that have just been okayed by the FDA, and we've just started in the last year giving them, which really are supposed to take out those plaques and tangles in the brain that caused Alzheimer's disease. Time will tell whether they actually improve the person. They're very expensive. They're hard to get because there are so many side effects, and you have to go through a lot of testing before you're admitted into the program. But for somebody who is youngish or who has early dementia, this can really be very important in terms of stopping the progression.
And somebody from the audience suggests, if you really are feeling very troubled by this, to go to a neurologist. I mean,
Yeah, so yes, if you really are troubled by it, you should get it worked up. And usually There's actually a whole specialty called cognitive neurology, which is usually in the specialty of neurology, and they do all kinds of memory testing. Often we'll get a head CAT scan or a head MRI just to be sure that there hasn't been a stroke or there's no tumor there. But yes, if you really are concerned, you should go, because there is a certain percent of people who worry that they have cognitive impairment who actually go on to have it. So if you're really worried, you should get tested. And a neurologist is a good place to start.
So I can't believe this. We're almost at the end here, but what I would like you to sort of end on, I do have to say that Tanya Gray has weighed in to say that you've been her mother's doctor for 10 years and that you're a national treasure, which I totally agree. And so what I'd like you to just sort of end on is how you feel that your experience with our mom changed you as a doctor, either in dealing with patients or their families.
I'm embarrassed to say that it has changed me a lot. And the reason I'm embarrassed, I think I told you, Julie, that there's the scene in the Titanic, in the movie The Titanic, where the guy who has been searching for the Titanic for 3 years, and then he hears Rose's story about what really happened on the Titanic, and he said, I never really got it until now. It embarrasses me because I was always good about making phone calls after somebody died or sending a bereavement card. But now I understand. I mean, I and my husband and our daughter were with our mother as she was dying. You were on the phone. Our son David, who was out on a first date, was on, we called him. So we were with her at the end, but watching it up close was just something that is so seared into my brain. And so now when I talk to people about it, I I talk to them differently. And I had a patient who, I had gotten hospice the day before because our aide suggested getting a hospital bed. So I signed up for hospice. I really didn't think I was going to need hospice, but I wanted to get the hospital bed. So she brought her little pack, which had morphine in it. And on those last few minutes, when mom was really having trouble breathing, I called the hospice nurse because I panicked, and she said, give her a squirt of morphine. So I gave her a squirt of morphine, and she did a little bit better. But then she didn't do better, and her oxygen, I had the oxygen thing on her finger, and it started to go down. And I feel badly because I lied to her. She said, how's my oxygen? And it was in the 60s. And I said, you're doing fine. It's in the 90s. I just didn't have the heart to tell her. And then she was gone. And I had a patient who went through the same thing with her mother. She was beating herself up that she had killed her mother by giving her morphine. And so I shared my story with her, and she wrote me the letter that I showed you, how it gave her peace. So it's changed me a lot. I mean, honestly, I've signed a lot of death certificates, but I think this was the first time in many years that I'd actually been up close to watching somebody actually die. And it's quite an experience seeing life move on to another place.
Okay, well, and now we have to move on to another place, but both here. And this has been so great. I mean, I think for me, having had this experience of coming to Boston much more regularly than we have over the years, I mean, we've come pretty regularly, but even more regularly, has just been really incredible to me. And I just feel really grateful for what you did for all of us, but especially for mom, because I really felt that until she once said to us, I asked her what she thought about getting so old. This was when she was pretty close to the end. And she goes, up to 100, it was great. She says, after that, for the birds. So thank you so much And I'm sure we'll talk after. Thanks to everybody. Before you tune off, on November 21st, we are going to have Adam Nagorny from the New York Times with us on At Lunch to discuss the results of the 2024 election. He has been covering elections for 35 years, including this one. I have a feeling it will be not as heartwarming as this conversation, but who knows? Thank you so much, Susie. Bye-bye, everybody.